So I don't want to make this too formal because I want you to be able to interact, because that's much better adult learning, right? So I want you to stop me. I'm going to show you bits and pieces of the lecture that I gave this morning, which is the same topic, but I want this to be a lot more dynamic than, I'm up here and doing the PowerPoint thing. So what I will say, though, is that I can't believe 20 years has gone by. It's completely different in structure, but the feel that this place gives me is the same. And I know it's made up of people like Colette, and this is an incredible place to go to medical school, really. I've been at Stanford, and I've been at UCSF. I have some relationship with UC San Diego. You are really, really in an amazing place to be going to school, and soak in every moment of it that you can. So I came here on October 9th, and I won't lie, I thought the leaves were really amazing, and I had never seen anything like that in Los Angeles, or where I grew up, or San Diego, where I went to college. But really what pulled me in was the fact that this is a place where there's a comprehensive commitment to liberal education, environment, health, and public service. And I thought, wow, that is really cool. And every time I interviewed and every time I went to the dean's office and met a new professor, you felt a little bit of that. And now as I return here, I actually feel it even more. And so we always think about things in terms of, well, we're all formal as surgeons, and you have to be a competent surgeon when you finish residency, right? But it's really important also to think about how you can be the consummate surgeon. And the consummate surgeon has really the things that are listed here. Can you be a competent surgeon without a lot of this? Yeah, probably, although it's a little bit of a stretch. But what I thought was interesting, and this is from a lectureship that I gave this morning, one of the things listed by the person who gave this lectureship, Dr. Wenner, who used to be a surgeon in St. Albans, is that part of this professionalism idea was attentiveness. And you're all sitting here because you're paying attention. Just by nature of the fact that you're interested in this class here tells me you're already paying attention. And why is that important as physicians and nurses and physical therapists and occupational therapists and administrators to pay attention? Because it's by paying attention that you figure out which communities really need you by their side. So attentiveness is a focus, it's a concentration, alertness, it's a caring, and it's observing patterns with an eye on the population. Things are crazy, right? A lot of times when you're in your residency, even as medical students, as moms, dads, grandparents, things can start to spin, right? There's a lot going on, and in our country in particular, that kind of a flow is really rapid. And I would just encourage you to take a step back and know who's out there and understand those patterns if you're really looking to do what you say you wanted to do on your interview, and that is to help people. And it becomes an incredibly worthwhile career if you just take a step back and observe the patterns and the populations that need you the most. So you probably are way more enlightened than I was as a medical student at this point. Population health. Have you heard that word? Have you heard that phrase? Excellent. And population health in a lot of ways is a vision of public health, right? We talk about health outcomes of a group of individuals. These are concepts that 20 years ago we didn't know anything about. And I say that in terms of being a medical student here. If it wasn't coming out of here, it wasn't coming out of anywhere. And we weren't formally taught about that. And I came here thinking I was going to probably do family practice. And this idea of public health was very real and known in 1995 or 1991 when I got here. But it was later that I got caught up in this surgical thing, and that's just a different story, and I probably need to be evaluated for that. But I don't regret it, because what it did is exposed me to these populations that really need help. So this idea of surgery and public health, and keep your eyes open, because if you're sitting in this class, I would love to see surgeons out of you. because a lot of times it was thought that surgery and public health were totally mutually exclusive. That the idea of surgery is that it's curative, it focuses on the individual, it's high tech, it's not cost effective. And in fact, that's plagued the world, and I'll tell you a little bit more about that too, by having that, that misconstrued. Now, is it important that if I'm operating on one particular individual, that I don't think, oh my God, I wonder how I can wipe out appendicitis in the world? That's not okay. I do have to focus on the individual when I'm in the operating room. But there's a lot of time outside of the operating room we all spend. Public health is a prevention approach. It focuses on populations. It's low tech. There are variable skills that are needed, and it's more cost effective. This is the mantra of public health. And there's equity involved. And as physicians in general, strip away the surgeon, just as physicians in general, and again as nurses, what is it that's most important in the way we treat people? It's with equity. You don't treat people differently. And the biggest nightmare is when you have some VIP come in and everybody's like, oh, we got to do, and the outcomes oftentimes are horrible because we've done things differently than we would have otherwise. So equity is really at the core of our practice, I think. Surgery, I would argue, things in surgery are public health. In fact, 11% of the global burden of disease, as according to the WHO, is treatable with surgery. 21% of injury burden is avertable by just basic surgical care. In sub-Saharan Africa, that's where the greatest burden is. And finally, we do have a better recognition of this. And if you think about it, what are the things that HIV/AIDS patients in sub-Saharan Africa end up dying from? Well, things like Kaposi sarcoma. There are surgical issues at the ends oftentimes of some of these communicable diseases, but really up front in the non-communicable. So we need to be part of that conversation now, and finally we are. Injury itself claims about 6 million lives worldwide. And so injury, in fact, I mean, that's huge, right? This was a picture taken in Sri Lanka after the tsunami because people were really concerned that landmines would start coming with the floods. Fortunately, it didn't end up happening, but it was a real scare. So, in fact, if you look at the burden of injury, 6 million lives, and if you take HIV, AIDS, TB, malaria combined, it doesn't kill as many people as injury every year. And we probably only know the tip of the iceberg. A lot of the funding has gone to HIV, TB, and malaria worldwide because they're really great advocates. And we'll talk about how important advocacy is in what you're interested in just by virtue, again, of you sitting in this class. So bottom line is, we want to talk about population health. Well, injury is the leading cause of death and disability worldwide for people under 60 years old. That's a big burden. And so, in fact, if you look, and this is a public health model that you've probably seen or something similar, right? You need all these components to be able to start to tackle it, injury included. So now we're in part of this conversation of public health, and there are all these pieces. Well, that looks scary, right? How do you make time for each one? You don't. A lot of them are sequential, and you get people who are passionate about the work to be by your side, and that's really what it's about. And you have to start out with an idea of surveillance, just like any other public health type of an issue. And then you look at your influences also. So having a passion is really important because if you can recognize a problem and you can do the surveillance, it's going to be really, really hard work. And I stand here saying that this is not a success story. There is a lot of work to be done. And our urban environments are crying out for this work to be done. And our rural environments are crying out for this work. So it's not perfect, and the only way you can go from day to day and not get burned out by it is to remember that your influences and remember the passion behind it. So I had a 16-year-old when I was an intern at UCSF who was violently injured. He was shot. He ended up going to the operating room. Of course, as an intern, you're like, I'll write the Tylenol order, but beyond that, I really don't know what to do. So, but I did get an opportunity to get to know him. And he was from an area of San Francisco called the Bayview, and really was angry and frustrated, and a lot of times just said, well, I'm not going to live to be 25 anyway. Eventually, he made it out of the hospital after his surgery. And before I was done with that rotation and ready to move on to something else, he came back shot again. And he went to the operating room. He went to the ICU. I left the rotation. He ultimately went home, but he was shot twice within a month period. And that's just unacceptable and an absolute epidemic in a population that's already dealing with other chronic diseases such as hypertension, obesity, really malnutrition, and a lot of the other things that are killing people at a much younger age. It's the same populations that are plagued, and it's intergenerational, and it's unacceptable. So I also read, and this is one of my heroes, Deborah Prothero-Stith, who many of you probably know. She wrote this amazing book, Deadly Consequences, and when I came here to finish my surgery residency, I read about gallbladders and stuff like that, but I also read Deborah Prothero-Stith, and her book, Deadly Consequences, How Violence is Destroying Our Teenage Population, and a plan to begin to solve the problem was very influential, and it drove a passion. And then it's being a trauma fellow, frankly, and being involved in this kind of a situation where you feel like sometimes you're standing at the bottom of a waterfall. And you're happy about the choice you've made because you're seeing people who are in particular in need, and you've developed over time the competency to deal with it. But when you're standing at the bottom of a waterfall and all you're doing is pushing water back uphill, you know there's something else that's got to happen. And one mantra of a lot of us as physicians, as healthcare providers in general, is that we want to see people through it. And just to get this young man through this part of it didn't seem like an appropriate stopping point. And what is really driving at this scene is really where you have to go. So injury surveillance, right? Public health. So you start looking, we looked at the world, and we know injury is a big issue. And then you just look at the CDC, 10 leading causes of death by age. And you know, again, in our country, that unintentional injury is the #1 killer of people between the ages of 1 and 44. And homicide is actually pretty close up there. In particular groups are affected. Now, I'm not going to get into the debate right now of gun violence and a lot of what's happening with the mass casualty situation in this country. There is some overlap, but I am going to tell you that the statistic that we see a lot of is if you look at the United States, we're beating out the next high-income country 17-fold for homicide from gun violence. Something's wrong. Canada has a lot of guns. They don't have the problem that this country has. And who really is affected? That's part of injury surveillance so that you can understand your target population. The severity and disparity of homicide mostly rests with African Americans, young African Americans. It's their #1 cause of death, and it's #2 in Latinos in this country. So you can start seeing patterns depending on where you are. And again, I would say wherever you are, it doesn't have to be about gun violence or stab wounds. Just look at the patterns of where you are, and you can make a big difference. So I'll tell you a little bit about the San Francisco story, which is an urban American story, but I want to pause for a second and get some thoughts from you before I move on, so I'm not just up here. Shall I continue? Okay. And if you're interested in learning more about it, we can chat later. Just as far as like if you imagine in 5 years you want to do violence prevention in some way. And I certainly work with not just surgeons, but nurse practitioners, nurses, family practitioners, so we can chat. So this is an old lecture hall at San Francisco General Hospital. It's a historic building now, but it's also completely earthquake unsafe. My office is upstairs from it. But what we did was we at least got permission to have what we call an advocacy center there, which is the top of the thing that I'll show you a little bit later. This man right here is one of the most amazing individuals I've ever met. He's really a brother. He's been with me for 10 years now, or I've been with him because I work for him. All I do is make sure the money flows. Mike Texada is about 45 years old. The way he likes to say it is, he has a rap sheet as long as he is tall. And he is unbelievable. I hear them down the hallway. I hear him down the hallway with clients. He's one of our case managers. He's our veteran. And watching him evolve over the 10 years and the influence he has on the community and on, this young man, this young woman, it's really quite extraordinary, and it's the closest I think I'll ever see in my life to a true angel. So San Francisco, you think of it as like this sort of thing, and by the way, this particular picture, I was looking at it last night, I thought, that's bothersome to somebody who does injury prevention. I really don't like this is hanging out here. These cars are coming, they can't really see these pedestrians. This is a nightmare, so I need to take it out. But you got to have fun, I guess. And there's like a hiking trail. There's a cliff right here. You can fall off. No. Anyway, San Francisco is a beautiful town, and I encourage you to check it out. There is a San Francisco that the tourists typically don't visit, and one of those neighborhoods and some of the projects is the Bayview Hunters Point. Bayview Hunters Point is a consolidated area of low-income housing. And I'll say it, and I'm going to bring this up in a little bit, but it's also an area where there isn't a lot of green space, and we now know actually there's data to support the fact that communities are healthier with green space. You've got lots of nice green space here in Vermont, as I remember, until it's frigid. But I ended up going to a community-based organization here in the Bayview because this is where our populations in need are hanging out. This is where they can, because housing is a nightmare in San Francisco. It's unaffordable. And when I pulled up to get out of the car, somebody walked over to me. He had his hood he was under the hood of his car because he was working on his car. He's about a 65-year-old man. And I had just gotten out of my car and I was looking at my sheet. And he said, "Are you lost?" And I said, "No, I'm supposed to be on Harbor Road. And it's, 10 Harbor Road is where I'm going." "No, you're lost." Like, I wanted to go. So what really was important about showing up that one day is that I showed up the next time and the next time and the next time. It's not, I sound like a Woody Allen thing, and it's 80% showing up or something like that. But you know what? If you stop showing up, you've done it again. You've let a community down that's used to being let down. And you just can't do that. You have to stay with it, and that's why you have to know you have the passion. It's just really critical. So this is about around the corner from some of the finest restaurants in San Francisco. So our communities are suffering right next to us. And so at the end of our wraparound, and I'll take you through what wraparound is, at the end we take graduates that year to Yosemite, and San Francisco is 7 by 7, and it's just a peninsula. It's the tip of the peninsula, right? Silicon Valley is down the long arm of it, and a lot of people are growing up about 1.5 miles from the ocean, and they've never seen the ocean. Now, the ocean's freezing in San Francisco. It's not LA. It's freezing, but they've never even gone over there to check it out. Oftentimes it's because they can't take the bus line because it's not safe to get over there. But this is often their first foray into the wilderness. It's really a great trip every year. So who owns this issue of violent injury? It's certainly, I think, now really clear that it's a public health issue. Well, C. Everett Koop, who amazingly came to UVM College of Medicine in 1995, I was completely starstruck. He was a real visionary guy. And he said, what, violence is a public health issue. It's not all about the criminal justice system. We need to get involved in this. And why is that? Well, because you're here, you probably are already one leg up as to understanding why that is. The other big influence at that time was Bill Schwab. He's a trauma surgeon at the University of Pennsylvania, and he started doing injury epidemiology while I was a resident, and I heard him say the bullet as the pathogen. And that just really makes a lot of sense when you're talking about an epidemic. And it also puts it in our purview and makes it our responsibility to deal with it. So injury surveillance on the ground locally was a really important first step if you want to start to try to tackle the issue. We did our own internal surveillance, and we found that 76% of homicide and assault victims had criminal history. African American men were 13 times more likely to be injured. And the most astounding thing is now from the 2010 census, 4% of the population only is African American. They make up 60% of our gunshot victims at San Francisco General Hospital, and we're the only trauma center. So this study was done when I came back from residency with the Department of Public Health, and it started us in understanding our target population. Was really important to be able to understand more nuances than that, but it got us going at least. So you want to identify the risk and protective factors, and this is where what you're doing is coming into play in such a big way that you get this, and that is looking at the social determinants of health. And there is nothing I can say that can overemphasize how important this is. And in Vermont, being in Vermont now, I'm learning more and more about the drug issues that the population is having. And it's really important to start addressing that, because I can tell you just from the heroin San Francisco epidemic, unless you start really managing that from a healthcare perspective, you're going to have endocarditis. You're going to have babies who are born to moms who are high. You're going to have all sorts of fallout from that. So as a healthcare community, we need to embrace the problem. So social determinants, it's a complex interplay of social and economic systems. Systems that are designed, there are systems designed to address people's health issues. And so a lot of this is shaped by income, power, resources. These are things that I think you know. And it can be applied globally, nationally, and locally. And what that means for prevention is that you can start taking those pieces and understand your particular populations and what social determinants are necessary to address to make a difference. Health and wealth, this is an idea that's usually a part of the global health discussion, the global surgery discussion as well now. And that is that countries can't move up by World Bank standards from low to middle to high unless you can develop some kind of an infrastructure for managing wealth and managing health. And the interplay between those is extremely strong. We see microcosms in our own country, and that microcosm is going to end up being the macrocosm overall. And so when I try to talk to people who, well, violence doesn't affect my life. Well, yes, it does, because you're part of the U.S. community. And in 2050, minority will be majority. And unless we manage what is ailing the minority populations in our country and our most vulnerable populations, we're all in this together. We are going down. So it's really imperative that we as physicians and people who have the respect of our communities get involved in these issues. So this is what it looks like, and you can apply policies and programs. You have, for example, in the disparities component, socioeconomics, geography for sure. You saw the difference in places in San Francisco. Race, ethnicity, and then the determinants factors, as you can see there. And so some of the specifics for violence are poverty, family dysfunction, this access to guns, mental illness. So how many of you have heard this concept of trauma-informed care? Okay, so trauma-informed care is this idea that when someone comes in violently injured, it's not the first time. They may develop post-traumatic stress from that event, but typically their post-traumatic stress is complex. And I would love to hear a whole lecture about that from you, but indeed this makes it very difficult. You can't move on a lot of the other social determinants until you address the issue of post-traumatic stress and other things that are really critical in our population that's violently injured. And hopelessness is a big deal. It was that 16-year-old saying, well, I'm not going to live to 25. But these are all things we can deal with. So protective factors, and this is really the crux of our wraparound project, is adult mentorship, interpersonal skills, commitment to school, access to resources. There was, way back in '97, there was a great article that was written in Science, which I don't read on a regular basis, but a friend of mine pointed out, social cohesion and willingness to intervene for the common good reduce violence in communities. So you absolutely, the community is the crux to being able to start to sort through the issues that are plaguing violence. And so then it comes to setting up, doing prevention and control and setting up services that will perhaps turn things around. There's one approach to violence that I really detest, and that is this idea of a scared straight sort of a thing. It doesn't work, and fortunately, I can only think of one right now in the country in a hospital. There are 33 programs that we know of, and this is a 34th, so I don't really call it a program, but this idea of blood and guts being a deterrent. They were showing videos from the trauma bay back to the patient. That's just not helpful. That's just not helpful. We have post-traumatic stress. We're already dealing with, why are you showing it again? So so we wrote an article on injury prevention because it got to be really irritating. Our model, which is a model that amazingly was sort of happening at the same time as a few others in the country, goes more like this. There's a teachable moment. So there's a cardiologist here, Phil Addis. I think he's still in practice. And when I was a third-year medical student, he started teaching us about the teachable moment. And it made a lot of sense. So someone who's had a heart attack starts to say, you know what, maybe I should get my diabetes under control. Maybe I should exercise and take those cholesterol pills and do things to make change, because it's basically just scared the crap out of me that I almost died from a heart attack. It works the same way with our population. They just don't know where the resources are. So they don't know alternatives, and we're there to tell them about it, because we have culturally competent case managers and community and city partners that are willing to provide risk reduction resources. And that really is the crux. This one in particular. I would love to think that, oh yeah, I grew up in the Valley in LA and I want to help you to change your life around. Doesn't work that way. I have my limits. So that's why it's people like Mike Texada who can walk in that room and say, you know what, I know exactly what you've been through. And there are a lot of things that we can do to turn this around. And it doesn't take one time, it doesn't take 2 times. It usually takes 3, 4, 5 to have somebody understand that it's for real and that Mike's not going anywhere. So we started to develop our program, and our program, the cornerstones, as I mentioned, the long-term case management was really key. It goes for 6 months to a year, but we see people sometimes after 4 or 5 years. It's not like, okay, you're good. They'll lose their job and they come back and we help them again. So we never close the door. And the provision of links to risk reduction resources is obviously really important. So our aim is to provide an intervention to reduce injury, recidivism, and incarceration, and to reestablish standard of care for violent injury and trauma centers serving communities affected by violence. These are my brothers. And they finally told me that I needed to hire a woman. So I did. It was embarrassing. They're like, yeah, you're turning red right now. So we have one, and she's basically like, it's funny to see her direct things around the office. I hear, well, what do you do? So she is amazing. She grew up in foster care in Los Angeles and has raised 3 children and seen them through 4-year university. She's quite incredible. The case managers, so Mike was chosen really essentially by a panel from the community. So was Javier. And so I brought in leaders from the Latino and African American communities. I did not make the decision as to who the case managers were. Terrell and Ruben were chosen because they knew of Mike and Javier, and so it goes. All of them have extensive case management experience before they got to Wraparound, because it's a hard environment, and each one of these case managers have lost clients to gun violence. So there are no absolutes. This is really hard work. And if they email me or text me and say, I can't come in today, I don't ask questions, because it's really hard. I've seen all of them cry. And our sessions sometimes for every Wednesday where we go over cases, cases ends up a lot of times just being, all right, we need to decompress. And so we go off campus and have coffee or whatever and sort of air things out. So this idea of seizing the teachable moment happens because there's a working knowledge of urban violence by all these guys and now Julia, and experience overcoming that violence. They're all extraordinary in that way. They do crisis management, and yeah, I get scared for their safety at times, but they're such pinnacles in their community. The respect that they get is really quite incredible, but I do worry at times about their safety. And when you're starting a program, you have to figure out if it's feasible. And this looks like a lot, but you start again just to take the pieces apart. And this is probably the most important thing, is the community willing to accept? Because it's just like when you go anywhere where you don't really come from there. The idea that you're going to come in and say, this is what I think you should do, is just, it's not cool. It's not going to work. And so there needs to be a dialogue, and a lot of the directives that Wraparound lives under are coming from the communities affected. So those dialogues are really important, and they need to be ongoing. It has to fit with existing programs. In San Francisco, there are a lot of community-based organizations. And it's really important to talk to people about collecting data, and the case managers hated doing this at first, but now they're all over our software program. They helped design it in the front end of it so that it would be a tool for them instead of a burden. It's important to collect data because you have to be able to reflect from a quality standpoint, and you have to be able to keep the program going in a sustainable fashion with funding. And you have to have access to referral networks, of course. These are just some of our community partners, but there are many more. The Trauma Recovery Center saves us slots so that we can get our individuals into mental health services. And then within the university, so Vermont is liberal. Burlington, like San Francisco, liberal towns. But when I first started Wraparound, I shared my office with my first case manager, who, by the way, said after 4 or 5 months, you know what, I can't do this. I still have 1 foot in and 1 foot out, and I can't go into half of the rooms. So I got to back off. But he was seeing clients in my office, and he was bringing people into my office. My office was in the admin, surgery admin area where there were other surgeons' offices and admin staff. And one day the office manager knocked on my door and said, Rochelle, I got to talk to you about something. People are just like not comfortable with the idea of Chevelle bringing in, his clients to your office. Did something happen? No. So what do you mean? Because a week ago those clients were patients down the hall in the hospital. So I don't understand. Never mind. And so it took some dialogue with the admin staff and some education about concerns, lack thereof, misconceptions. So even in a liberal San Francisco environment, it's tough, and in the beginning to have this organizational climate all in place. There's some CEOs who have looked me straight in the face and said, why would I want a program like this? Trauma is a cash cow. And it's like, wow, you just don't know where to start from there, right? So Wraparound, I'm going to show you this one for the sake of time. We see people at the bedside. As I said, sometimes it takes 2 or 3 different times. We actually lowered our age to 10 because I had an 11-year-old who was shot in the neck, and it was not a child abuse situation. And so the case managers enroll high-risk individuals. We don't have a set thing saying, being high risk, it's their judgment is the best. I have not been able to quantify that judgment for 10 years. But they nail it. And so they do an assessment and look and see what is necessary as far as risk reduction resources when people are ready to receive them. And that may take months. And in fact, the mental health services is so key that really other things can't happen without that, right? Because the kid can't concentrate in school if something is happening during the daytime or didn't get any sleep because he's having nightmares. And so these things need to be addressed before you can say, okay, let's move on and get into a good school situation or find a good job. you know, everything hinges, I think, on mental health. Vocational training program that we have, these are just wanted to throw a couple of examples up on some of the things we do. So we have this great relationship with a place called Friends of the Urban Forest, or FUF, but Mike calls it Fluff. And it teaches our clients, once they're physically ready, how to be arborists. And now the Friends of the Urban Forest love these two guys so much that they now, in turn, have them teach suburban white kids skills in arborist. I love it, and the pictures coming out of that is just the coolest thing ever. And they're given job opportunities if they go through the whole thing. Pitfalls, we tried immediately to get them into a 40-hour-a-week situation. They had never done that. That wasn't something that was feasible for them. So we started at their pace and then ramped up as they were able to, and it's been really fun. This advocacy center that I mentioned, so we offer tutorial services. We have partnerships with the school district. Life skills, there's this really terrific success center they call this job readiness program. It's a community-based organization. They come to us. The hospital is really neutral territory, so we try to keep things within. And then we have this great project Rebound at San Francisco State University. We now have 7 people enrolled in a 4-year university from our clients, which is really exciting. And we run men's groups. Terrell usually runs those. We have this program that I'm ashamed of the name, but it was developed. The name itself was thought of by a juvenile justice judge. So it's called Weapons in Minors Possessions, or WIMP. So we need to change the name, I'm aware, and that's why I didn't put WIMP anymore here. It basically takes kids who are 12 or 13 years old, first offenders, so they may have been carrying a knife to school or something, and they come to us, and we have our clients who have graduated wraparound basically talk to them about violence and about how unnecessary it is that they get involved. And it's amazing to see this, because you see the transformation at that point. So it empowers our clients, makes them feel like, yeah, you know what, I have something to say, and it's of real value to my community. So it builds social capital, and we work with a lot of different groups to be able to do this. It's been a really exciting opportunity for our clients, and they earn money by doing these lectureships. It's wonderful to see the confidence development during these times. So you have to evaluate, and I'll just speak briefly on that so that I leave some time. This is just a screenshot of our software. It's really necessary that we have this. We're right now looking at our 10-year, but early on we really took it apart. You have to think about the components of prevention efforts, and you look at formative. Are you hitting your target population? Is it feasible? Process, impact, and outcome. And then we wanted to look at what predictors are there of success in the program, and success meaning a lack of recidivism and that people were not leaving the program prematurely. And early on, what we found is that we had a real problem with driver's licenses. We were not able to do it. And this was great in the sense that we found where our pitfalls were. What we were not recognizing is people couldn't get their driver's licenses if they had 100 parking tickets and they weren't allowed to sit for it, or they couldn't read the test. So we had to take a step back after we were, all excited about starting this and getting people driver's licenses, which is important because it opens up job opportunities for them, like trucking. So we learned something from that interim analysis. And then we looked at risk reduction resources that are essential for success, and we looked at our 6-year recidivism rate. What we found was that we were approaching eligible people, and this was because at some point before that, we went to our city supervisors. The city of San Francisco pays for a lot of the salary support, and said, look, we're only hitting about 44% of our population of violently injured people right now. We need another case manager. And so because we were able to get a third one, and now we're up to 5, but because we were able to get a third one, we were able to approach a lot more people. And so this is what our enrollment and decline looked like at that point. We're now, as I mentioned, into doing our 10-year evaluation. So we were having a much better success rate. We understood a lot more about what was necessary. we used to not take people to mental health services. Now the case managers sit in the first session, which has been really, really helpful. And we found that our recidivism rate was 4.5%, and that was from a historical rate before the program started of 16%. So we found that mental health and employment were the two things on logistic regression that looked like they were independent predictors of success. I thought it was actually going to be housing, and that it was important, but not as much as mental health and employment. And then, yes?
Any housing or a change of location of housing?
It's really any. The housing is either really unstable in a lot of our clients, or kind of the couch surfing sort of thing is going on. Or they just have to get away for at least a while. In the 10-year, it looks like it's going to be more significant in this odds ratio, just from looking at it before I left for this trip. And then the case manager exposure, the case managers have deemed this dosage. I love that they call it a dose of case management. In the spirit of working in a hospital, that's what they say. And so not surprising, it turns out that if you have more exposure to the case managers, your chance of success after the first 3 months is higher. We're trying to qualify that in some way too. I just know, the crux of the program are the case managers, and how to really capture how important that is has been challenging to us across the country, actually. So over 6 years at our institution, our injury recidivism rate decreased fourfold. Mental health and employment were most predictive of success, and the value of early high-dose intensive case management was essential, as they say it. This was our 10-year party. So it was an open house. This is one of our murals that was done by our clients. Life too many, meaning life's too maniacal. I love, though, that there are components like the maize fields where people come from, basically, and then this educate to liberate, and a guy breaking the chains from prison. Just a lot of power in this. And there's a mural on the other side as well that is just as powerful. This particular individual runs this San Francisco state program, IERTO. He has a felony record and is unbelievable, and now shepherds people through 4-year degrees. Marcy she's a social worker. She helped start the WIMP program. And when Marcy was 16, she was interviewed, and you can find her on a documentary. The person asked her, so how easy is it for you to get a gun? And she said, you got a car? That's Marcy. And this is Lynn Westry, who I've known for 15 years. Her passion is unlike anybody else's. Her daughter was killed in a drive-by shooting 3 years before I met her, and she is a stalwart in the community and part of the Department of Public Health. Here's one of our clients, and here's one of our clients. So we had a nice party, and now, as I mentioned, we're doing our 10-year evaluation. So I'm going to end with policy and advocacy, and I won't go into details of one of the analysis. I'm happy to talk to you about it later, but city leaders, so Gavin Newsom was our mayor, and he made some statement about how he was going to reduce the homicide rate, and then I think turned around and said, oh crap, how am I going to do that? And so he started talking to those of us who do violence prevention and started to fund some of our salaries. The city and state departments, we've gotten funding from them, foundations, federal government. It's basically advocacy and using not just data, but understanding what people need to hear based on who your audience is. So it's really important for them to also know that it is cost effective. So when you're talking to people in political positions, they want to know about the cost effectiveness too. So we've been able to do that. Ultimately, we want to change policy and have these types of programs, if they work, and we have to do robust quality improvement, if they work, they should be part of the fabric of trauma centers that deal with a high burden of violent injury. So, for example, early on, we had a master's from Berkeley student who found that wraparound would be cost neutral if it saved just 3 lives. And that's more so now. This was done about 6 years ago. So we now did a more sophisticated analysis called a Markov analysis and looked at even if you have a lower % of recidivism in your particular city, that programs like this are actually cost effective. So the main thing that I wanted to mention so that we still have time is what do we do now? So we're building a multi-institutional database based on 7 programs that exist in the country. We have 4,000 clients in it, and we're starting to do the analysis of impact outcome and outcome evaluation. We want to use this instrument for emergency medicine, for surgery, and for social workers. We go to our professional societies and do this kind of policy and advocacy work, and it could potentially change policy in trauma centers, so that's exciting. Here's our national network. There are 33 programs, as I mentioned. There's a paucity of programs here. There's not a paucity of gun violence here. It's been very difficult for us to engage the South, and that's the bottom line. Actually, there's a program now in Portland, but there's not that much violence there. So this was an earlier map, but I couldn't find an updated one on our website, so I got to go back and tell them that. But we're really close. We work very closely together, and just a group of really inspired people, especially looking at, just around your corner here, Boston. There's an emergency medicine physician, wonderful advocate. So why surgeons? Why physicians in general? Why do this kind of work? That's not necessarily what we were trained to do. Although now, fortunately, I look out and I see that you are getting trained to do this. But why should we involve frontline healthcare providers? But I just turn it back to people and say, why not? And who else? These are our patients, and to see them through all the way in these horrible situations, that's what it's all about, right? And I don't mean that people need to be completely steeped in the daily or the weekly case management sessions, but there's so much you can do by just putting your white coat on and understanding the issues and having ideas as to how to solve them and interacting with communities that need you. So with that, I will leave you with this last, this was on a cork board of one of my patients. I know how you feel because I've been shot too, 3 times, and it hurts, so don't think I don't know how you feel. And this was in the room of that 11-year-old I mentioned. So out there, and I never met this particular individual, but this is injury recidivism, and it's the get well card for an 11-year-old. So we need to face this as our own. It's being displayed in our hospitals, and it certainly is within our purview, and there are things that you really, truly can do if you have the passion for it. So with that, that's it. Questions and please comments, and I know a little bit of the complexion of Vermont, and I know fortunately that your violent injury situation is not like it is in San Francisco. However, this type of a model is applicable in a lot of ways. If it's fall prevention, if it's substance abuse, you can start picking these things apart if you pay enough attention to the social determinants. So look at it from whatever drives you. Yes, sir.
I believe that racism is a spiritual disease, and as a person of color, it impacts me in terms of my physical health and my mental health. And I believe that black on black or brown on brown or black on brown crime is a function of internalized racial oppression. So how might these clients be supported to unpack that? Because without really understanding why is that hate boiling inside of me, we react on each other.
We just about 4 months ago, these men's groups that I mentioned, Terrell Henderson, one of our case managers, organizes them. But we have a spiritual leader from the community who really actually has created the curriculum. We're about 2 months away from it being completed, and so I'm not sure right now. There are 20 young men who are involved in this. That is absolutely something that I hear, I'm not allowed in, but I hear in the hallway that discussion is happening, and it's been eye-opening. And there are times that people have to step out because I see them go get water. thank you for bringing that up. It's just now, as I've become as a surgeon, like more recognize a lot more of the mental health components of it, also recognize the spiritual components of it. And so we're finally starting to address that. And I think the group at Drexel, it's called Healing Hurt People. John Rich and Ted Corbin have also done an amazing job of being ahead of the curve in bringing that into their program. Yeah, thank you. Yes.
This is not nearly as meaningful a question, but I come at it from the more community health side, and I'm curious to know if you have any comments about, I saw you're working to build a database and share patient data across communities and states, and so can you speak a little bit to what that experience has been like, and any barriers or challenges you've either come across or you've actually gotten across?
Definitely, you know, I have to say there are a lot of things at UCSF like, why are you making me do this? But the Institutional Review Board was really tough on me when I started to want to, you know, at first I said, we're just having a program, and then I recognized I got actually, I need to get it funded. And so, like, all the leaves are brown, you know, it's like it doesn't work that way completely. So, they really put me through the ringer as far as just HIPAA and confidentiality, because they were really afraid of self-incrimination. And there's this thing called a certificate of confidentiality that the NIH provides. It takes about 6 to 8 months to get, but that really helped because the case managers then can't be subpoenaed. And as soon as the community also recognized that, or that we started to tell them that, the trust became much better. And in the databases, those are locked, and those are day-to-day databases, but anytime I download things to an Excel spreadsheet and do the whole statistical analysis, that's de-identified data. But at first we had one wing of wraparound that was absolutely, you know, these are clients who want to be in the program, but they don't want to sign the consent, and we had people who did, and over time, the people who wouldn't sign the consent just almost completely disappeared. We get a few, but I don't keep them out of the program. We just don't record them. Yeah.
This is kind of related, but of those, when you're enrolling, of those who refuse, have you looked at the reasons for that? And also, like, if there are people that initially refuse and then there's recidivism and then they end up deciding
to be in the program at all?
Yeah. After multiple traumas, or like what keeps people from doing it, and what sort of tips them over the edge to wanting to make the change?
It's a great question. And every time I ask the case managers, usually Mike Texada said, "Oh, it's because he still has stinking thinking." I'm like, well, tell me more about that. So people have to be ready, and the teachable moment comes at different times. And you're right, you know, sometimes people will refuse by the time they leave the hospital, and a lot of my colleagues who have these programs are emergency medicine physicians. People are leaving the ED, but they do, but they make contact in the ED. But the teachable moment isn't always right at the bedside. It may be triggered by other things, like, for example, there's about 5% of our population that honestly, they come back and say, okay, wait, I got this card from Ruben Marquez, and I have this insane hospital bill, and I don't know what to do about it. And it pulls them in, and that's fair, you know, because then it's like, okay, let's have some dialogue, and suddenly you see them in the wraparound office. But there are people that it's just like, whenever I see someone who already has a laparotomy scar, I'm like, oh man, okay, what happened there? And a lot of times it's just we either missed them because we didn't have the staffing for it, or they did refuse and they just were not ready. And we're at about 15% with that, like adamantly refusing and not coming back after hospital bills or something else. Yeah, it has to be a partnership.
Opiate abuse or substance abuse. How does your program address that? Do you refer into substance abuse programs that work hand in hand with you?
Yeah, it's mostly the trauma recovery center, so they can manage the mental health issues beyond substance abuse or in addition to substance abuse. The issue with people coming in, like we are starting to set our own standards based on the case managers based on how much pot people are smoking. We read that as they're still trying to dull this particular thing, but they'll argue, well, it's not illegal, and so why don't you let me do it? And the case manager, I'll hear him say, yeah, but having a beer isn't illegal either. You don't come to work that way though. And so they have set their own standards. So we do a little in-house tough love stuff. But if it looks like, look, this substance abuse issue is an addiction problem, it is as a result of really not getting the appropriate mental health care, yeah, we have a referral line for that.
Services available in your area?
It varies. It depends on the volume that they're facing, because we always want it now, somebody to go in now, because a lot of times our population's like, all right, if it's not now, then forget it, and we'll lose them for a while, or the case manager will find them on the street and say, get in the car. Yeah, so it varies based on the volume in the city of resources that are open and ready at the time.
With a shortage of those services, I mean, there's an awareness of it, and I think there's a sincere attempt to address it, but right now there's waiting lists and all that.
Which it sounds like in Vermont right now is a desperate need. Thank you so much for your attention. It's nice to be back.